I'm going to talk to you about the role of integrated support to management in patients with acute cardiogenic shock. These are my disclosures. In terms of the National Cardiogenic Shock Registry, this is a investigator-led, multi-center trial, single-arm prospective study. There's no involvement of any of the companies. We own all the data. We put all this together, and so it really is an investigator-initiated trial. We have to talk a great deal about New York, because this is really where some of the foundation for shock therapy and outcomes occurred. Killip and Kimball published this classic report in patients that came in with acute cardiogenic shock, a 90% mortality, and more importantly, within 10 hours of onset of shock, a 50% mortality. So this is a lethal disease that it kills people very, very quickly. And I think the one message that I would leave to you today, whatever system or strategy you design at your institution and in your region, getting to these patients, identifying them, and treating them as fast as possible is going to be the thing that's going to improve the outcome the most. Well, you know, one of the biggest criticism we have about mechanical circulatory support is that there's no evidence for it. There's no randomized trial. If you're looking for randomized trial data in acute shock, I'm sorry, you can go out to have some coffee, because there is very little. The only randomized trial was the angioplasty with a shock trial that Judy Hochman did here in New York and published in 1997 that showed that angioplasty was better than acute than medical therapy for the treatment of shock. I treated my first patient with acute infarct angioplasty in December of 1983, and I treated my first patient with acute cardiogenic shock with angioplasty in January of 1984. So I've been doing both of these therapies for over 30 years. And while we've made enormous advances in the management of reperfusion therapy for non-shock, there's been really very little difference in outcome. In 1987, we published outcome data, 50% mortality in patients treated with angioplasty with or without balloon pump and cardiogenic shock. So you're going to have to take a look at this, and you're going to have to say, where do you fit? Okay, now if you want guidelined, mandated care, this is a ski slope that has been groomed. It's nice. It's beautiful. Sunny day. You went up there with some hot cocoa in hand, and then you're on your slopes, and you can easily go down. All of the rocks and boulders and everything are out of the way. So that's kind of very well proven mandated therapy. But this is really where we are with acute shock. I think after 30 years, we still are here. Now, you have to decide where your comfort level is, because tomorrow, when you go home, you're going to be treating patients with acute shock. The DANGER study is not going to be available for 3 or 4 years. And so for the next 3 to 5 years, how are you going to be managing those patients? And that's kind of what we decided to look at. And again, I think that you want to be here exploring and creating new frontiers. There's lots of danger with this. You don't know what's on the other side of the slope. You have to be very well prepared with the skills that you've developed as an interventionist to treat these patients safely. So where are we today? This is the data from the culprit shock trial. Dr. Sharma alluded to this as one of the major advances. Mortality, 50% mortality in patients treated with angioplasty in 2017. This is exactly the same data as we had in 1987. So we've made absolutely zero impact on improvement in survival in patients in the last 30 years. And it's largely because we really haven't had very effective tools to treat cardiogenic shock. Data here again from New York Hospital demonstrates that one of the most potent indexes of survival is cardiac power output. Again, one important tool I want you to remember is the blood pressure, in particular systolic blood pressure or augmented diastolic blood pressure, is completely inadequate in dealing with these patients. In order to properly treat these patients, you really have to know what the cardiac power is. It's a very simple, something very simple to calculate: mean arterial pressure times the cardiac output divided by 452. 1 is normal, and you see that when patients have a relatively well-preserved cardiac power output, a very low mortality. When the cardiac power output drops below 0.5, the mortality skyrockets. So this is kind of the bend point, and one of the things that we're trying to teach as a parameter. Just like with FFR, everybody knows what that is right now. I'm hoping that within the next year or so, the discussion that we're going to be having on acute shock is going to be related to CPO. Well, how does balloon pump do in the United States? Still, 40% of American patients coming into the hospitals with acute MI shock are treated with balloon pump. This is the one randomized trial that demonstrated looking at CPO, and you can see that there's a slight increase early on in CPO, very negligible increase, but then at 24 to 40 hours, actually no increase in CPO with balloon pump compared to medical therapy. And so it's really not surprising that when the study was completed, that there was absolutely no difference in outcome for patients treated with balloon pump. Europeans have caught on to this. Balloon pump is much less frequently used now for management of shock in the United States. Again, people are, it's kind of astounding to me. People are saying, I need data, I need data, I need data. Well, there's been 4 randomized trials showing that balloon pump is ineffective, yet American physicians are still using balloon pump for management of acute MI shock. So this is I'm not Buddha, but this is a really profound statement. I think if you want to treat shock, you have to treat shock. Okay, so treat the shock, and in order to make patients survive, you have to treat the shock. You have to get them out of shock if they're going to survive. And so there is now a family of support. Again, I'm a consultant for this company, but none of this is really funded by Abumet other than an unrestricted grant. There is now a family of support devices that have been FDA approved for treatment of acute MI shock. This approval occurred in April of 2016, and this really now has given us an opportunity here in the United States to really learn how to use these devices profitably to improve outcome. From the CVAD register, we found that more vasopressors are harmful for these patients, and I want to explore that a little bit further with you in the trials. If the patients are not on any vasopressors, a 30% mortality. If they're on 4 or more vasopressors, a 74% mortality. Now, you could argue that the patients are sicker, so they need more vasopressors, but I'll show you data that independent of severity of impaired cardiac power output, more vasopressors are more harmful. And this is something that I think we have to study much more carefully. If there's one thing that you're going to do at your institution to improve outcome, and we've seen this in 3 different databases, is to monitor the right heart cath. Monitor and check cardiac power output. This will help you drive parameters to improve performance for your patients. And you can see that in the CVAD registry, if you didn't use a right heart cath, a 63% mortality. If you did use it, a 49% mortality. So this is one really important method. A second is that delay is really harmful. We found that if you put the Impella in before you do the angioplasty, survival is increased, and time is absolutely essence here. If you can treat these patients within an hour and a half of the onset of shock, a 60% survival. More than 4 hours after the onset of shock, at 26% survival. So we really have to work on our algorithms here in the United States to get these patients into the hospital very quickly. We did this in Detroit. We got all the health systems together. We decided to collaborate and use these teachings that we've done in a systematic fashion where we get the patients identified, treat them very quickly, and then perform the therapy. There's actually now in the National Cardiogenic Shock Registry, there's 17 patients that had active CPR while the Impella was being inserted. Now, so I don't have randomized trial data on those patients, but I know that 13 of the 17 survived. And so these are patients that were literally dead that have been resuscitated. This patient had a proximal LAD occlusion, and then the artery was open. And this is a patient that was treated in our initial cohort of patients. This is the group of investigators throughout southeastern Michigan. This is actually that patient. They thought he was going to be on a transplant list. He went home 7 days later with an ejection fraction of 50%. So there's anecdotes like this, but again, this is stuff that we haven't really been able to treat before. These new techniques are so powerful that some of these patients that really would have literally not survived to get out of the cath lab are now having a chance for survival. So we put this registry together, first at Detroit and then went national. This is our group. Dr. Basir is my co-investigator, and our entire treatment group. Mike Hacklick, he's our national coordinator, and this is the method of reaching us if you're interested in collaborating with us. We now have 68 active sites that are actively enrolling patients throughout the United States. Importantly, we have both academic and community partners. I think it's really critically important to have techniques and methods of treating patients that are at non-academic institutions. More than half of the patients coming into the United States with acute MI shock are being presented to community hospitals. This is the eligibility. They have to have electrocardiographic markers suggestive of ischemia. They have to have prolonged hypotension. Again, we're trying to really mimic the randomized trial data from Judith Hochman. They have to have end-organ hypoperfusion, and then if uncertain, you have to have a cath demonstrating a cardiac index less than 2.2 or a CPO less than 0.6. So these are really truly shock patients that we try to mirror the severity of illness of the acute MI shock trial. We identify the patients very quickly, femoral access very quickly, and then put in mechanical circulatory support. This is really the key thing. And then after the procedure, we do a right heart cath, or use this right heart catheterization in measuring outcome. We won't go through the entirety of deciding, but you do have to make sure that the patients don't have RV infarction. We found, in fact, in the trial that only about 5% of the patients have RV involvement. So if you get to these patients very quickly with left-sided shock, it seems as though that RV shock is less and less prevalent. So this is now the outcome data. We presented this at SCAI at the late-breaking trial. There a total of 289 patients were screened. There were 171 trial-eligible patients. And astoundingly, 98% of the patients left the cath lab alive. So we can resuscitate these patients. We can get them out of the cath lab, and 72% survived to discharge. So now this data, I think, demonstrates that we can do this consistently around the country in both academic and community hospitals. If we follow a similar protocol, we're going to get an improvement in survival. We looked at now the other trials that have gone on, the shock data, the culprit shock danger, and this is now our trial. In comparison, a slightly younger group. Most of the patients are in vasopressors. 40% of them had cardiac arrest. Importantly, the blood pressure was 79/50, elevated lactates, and 77% of the patients had elevated lactate levels, a 70% survival compared to other trials. And this is really right now the highest rate that's been reported for survival for this specific patient population. We wanted to identify then, can we figure out who's going to live or die? Remember, 98% of the patients leave the cath lab alive. You can start seeing that the cardiac index is definitely lower. The thing that I want to emphasize to you is that the blood pressure is identical. The blood pressure is just absolutely misleading in terms of management of these patients, because you can get a blood pressure of 113 at the expense of a marked increase in systemic vascular resistance, a marked decrease in cardiac index, a low CPO, and then a low PaO2 SAT. And these patients are going to do very poorly, but just using a blood pressure alone as a marker is completely misleading, and you really can't drive that. So looking at other parameters, the survivors versus non-survivors, again, the cardiac output is lower, cardiac index is lower, CPO is definitely lower, and the SATs are lower in the patients that are non-survivors. So these are methods that, and this is why I think using right heart catheterization is so important, because you can really start driving management decisions for these patients. Conversely, immediately after the procedure, the patient's cardiac power output is 1 and the SATs are 62. So you can see immediately after you're done with the intervention whether or not the patients are in trouble or not. And then the next phase of our investigation is going to be looking at these patients to see if we can even more aggressively support these patients to improve outcome. At 12 to 24 hours now, you're starting to see similar kinds of trends. Blood pressure is about the same. Systolic blood pressure is slightly higher, but now you're starting to see elevations of AST, you're starting to see elevation of lactate. Conversely, the lactate is going down in these patients, cardiac power is elevated, and SATs are increased. So you're starting to see now hemometabolic parameters establishing in patients that are surviving. Within 12 hours, you get a very good picture. The blood pressure's up, lactates are washing out, saturations are increased. And conversely, the converse is a problem. And again, I think this is the real reason why these patients are dying. It's not because their heart is dying, it's because the extremities, the bowel, the gut, the kidneys are all having hypoperfusion syndrome, and this is what's going to ultimately cause the patients to expire. similar kinds of patterns at 12 to 20, at 24 hours. I would go back in terms of what we're doing now at our institution, and what I would advocate people. 12 hours after the intervention, I think this is where the heart team should meet, where the shock team should meet, where the surgeons, the VAD surgeons, the perfusionists, and all of that can decide on whether or not these patients are trending in the right direction or not. And then in these patients that are not doing well, this is really where a time where you can still intervene on these patients before they have severe end organ damage. So this is post-procedure. Again, cardiac power output, CPO is elevated, SATs are elevated in these patients. I'm going the wrong way. Okay. So in terms of inotropes, if you aren't on any inotropes, and this is the current data from 143 patients, 18% mortality. If you're on more than 2 inotropes, a 58% mortality. And this is really, I think, another thing that we're driving at. We're trying to decrease the use of inotropes by supporting the patients mechanically. Look at this outcome. This is really interesting, probably some of the most interesting data that I have to show you. We were worried that you're on a bunch of inotropes because you're really sick. Well, look at patients who have a CPO that's relatively normal. If they're not on any inotropes, they have an 85% survival. If they're on 1 inotrope, a 75% survival. And then if they're on 2 or more inotropes, a 57% survival. And so what this is telling me is, independent of the level of cardiac performance, the more inotropes you're on, the worse the outcome for these patients. And I think this is really something that's quite telling, and it's going to really have a huge impact for us. The other thing is that if you're on more than 2 inotropes and you have a CPO less than 0.6, you're in real trouble. And these are the patients, I think, where more aggressive measures are going to be required to improve outcome. So I'd like to summarize for you that there's been an enormous improvement in survival over the years. If you take a look, the initial major jump in survival came with angioplasty of acute MI shock. No question that we've improved survival compared to historical control, but that's plateaued over the last 30 years. And data that we presented in 1988 is very similar to outcome that was presented in 2017. Now I think with more powerful, more widely available mechanical circulatory support, that we're going to be making a large impact on these patients. And I think that that's for the last part of my academic research career. I'm really going to be focusing on how we can improve survival for acute MI shock. Again, I think this is early in the stages. The Impella catheter was approved in 2016. It's going to be 10 years, just like with angioplasty, just with any other methods. It takes 10 years for us to fully develop this field, but I'm extremely optimistic that we finally got something that we can do to improve the outcome for these tragically ill patients. Thank you very much.